blah, 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 blah.
Welcome to the Our Forever Smiles podcast, a podcast created to support mothers of children who were born with clefts and those who love them. I'm your host, Laura Arroyo, and I'm also a mother of a daughter who was born with a surprise cleft palate. I know the challenges you face every day. Whether you have just learned the difficult news of your baby's cleft lip or palate, you're in the midst of pre-op or post-op, or you're an OG cleft mom, this podcast is for you. In a weekly conversation, we will talk about everything from feeding and speech therapy to surgery and school. We'll share tips from guest experts and advocates and even share a little joy in the process. You can listen to Our Forever Smiles wherever you listen to podcasts. Don't forget to subscribe and stay tuned. Hello and welcome back to the Our Forever Smiles Cleft Mom Diaries and Support Podcast. I am Laura Arroyo. Before we jump into this episode, I would like to invite you to join this community to hear conversations with other cleft moms and advocates that will help you feel supported along your journey. All I want you to do is click on the Facebook group page that is linked in the episode notes. You can speak directly to the guests from this podcast, ask questions, and talk to a community of cleft moms that are eager for answers, but also willing to help. As a note, we do have a cleft surgeon on the podcast today, Dr. Nguyen, but he is not your cleft surgeon, so we do not intend for you to use the information that we share here as medical advice. We are parents and advocates who love our children, and we're just sharing our own personal experiences. Also, if you would like to share your story on the podcast, please feel free to reach out to us at ourforeversmiles@gmail.com. Again, as I've mentioned, we have a doctor here today. So excited. I know that you all ask for varying information about the cleft journey in general, more specifically during surgery time, because it's the time that we're the most anxious and we have the most questions. And we tend to worry about this as it comes up. We have a surgeon here that will answer all of our questions, hopefully. Dr. Nguyen is a professor of surgery at the University of Colorado School of Medicine, section chief of pediatric plastic surgery, chair of plastic surgery at Children's Hospital Colorado, and co-director of the Cleft Lip and Palate program. He is a pediatric plastic and craniofacial surgeon, and his clinical practice includes cleft, craniofacial reanimation, and global surgery. Welcome, Dr. Nguyen.
Thank you so much.
Thank you for being here with us today. So why craniofacial surgery?
I'll try to make it short. As you mentioned, I'm a pediatric plastic and craniofacial surgeon, but what does that mean and how do you get there? The short answer is I did college, so 4 years of college, 4 years of medical school. I did 7 years of general surgery training. Part of that was a 2-year research fellowship. This was at NYU. Then I did 3 years of plastic surgery training. That was at UCLA. And then I did a year of pediatric craniofacial training, and that was up at the Hospital for Sick Children in Toronto. So it doesn't sound that long, but that was 11 years. So it was a hard-fought 11 years, but it allowed me to do something that I truly love, and that is taking care of kids and being able to really take care of everything from birth to adulthood, anything from a congenital perspective, a trauma perspective. And I think of myself as a true kind of problem-solving type of discipline. And for plastic surgery, cleft lip and palate are one of those kind of gateway drugs because it's a magical process to change someone's life in a short amount of time to do what we think of as a relatively straightforward surgery. But we know that this has such implications, not just on that child and their entire livelihood, but the entire family and their expectations for how their child's going to grow. So it is really a wonderful job. I wouldn't trade it for anything, but it allows me to take care of any problem that comes my way.
Yeah. I see you mentioned trauma. So I guess So it's not just, you don't have just like cleft lip and palate patients. This could also be craniofacial surgery based on an injury or something like that as well.
Yes. So it's my area of expertise is basically from the collarbones up. So that includes the face and the skull and all the bones and soft tissue that go along with it. But at the same time, I consider myself a head to toe surgeon. So anything from lawnmower injuries to extremities to I still do some body and trunk type of surgeries. But my practice is all in kids. It's all reconstruct for the most part. So it's pretty fun. Every day is different. Everything from it may sound gruesome, but changing a baby's skull in order to allow the brain to grow and putting bones back together to doing things like a cleft lip surgery that's again are 3 to 6 month old babies to doing jaw surgery. That's what orthognathic surgery is. So a lot of times in patients who have cleft lip and palate, they're going to need jaw surgery as they get closer to adulthood. So I'm able to provide that. And the whole gamut, every day is different. It's fun to see a patient and approach them as a specific individual and figure out what would be the best thing for them.
Yeah. What's your favorite surgery to do?
I think you're preaching to the choir here, but I do love a good primary cleft lip surgery. Um, no matter how long you've been doing this, it can keep getting better. Every single case I learn from, and you just want to keep striving to get better and better. So I do love that. I do love rhinoplasties, and the majority of my patients are cleft rhinoplasties, meaning kids who have finished their cleft journey. And this is the cherry on top, being able to do a full rhinoplasty at the time of young adulthood. So as they're going off to college and really allowing them to be their full self. And the last one, again, related to cleft, is orthognathic surgery, jaw surgery. I think it makes such a big difference in the profile, but also the self-esteem and function for kids with cleft and non-cleft kids who need jaw surgery. I really love those. If I'm gonna add a fourth one. I like this is non-cleft, but for some kids who are born with an inability to move their face or facial palsy, you may have heard of Bell's palsy, things like that. There are some strategies to get them new smiles. And without going into the details, that could be a pretty complex surgery where you take muscles from different parts of the body and rewire it with nerves and allows them to smile again.
Oh, wow. That is like fascinating because, and then like you can actually see that in action. Like you could see them
Mm-hmm.
going from not being able to smile to like being able to smile. That is wild. What?
It's pretty cool. It's crazy that it works at all, but it's pretty remarkable when you see those patients come back and they're doing something they never could do before.
Yeah. Oh, that's fascinating. So you mentioned the jaw surgery. So in preparation for that, do you all do like the jaw distractions first? Is that involved in that procedure at all?
So before we get into what that is, so yes, I do distraction, but distraction is basically it's a tool. So it started off in the 50s with orthopedic surgeons who were trying to lengthen your legs so that they match each other. So that was a Russian surgeon named Ilizarov. But that had not been applied to anywhere outside that area up until the late 80s, early 90s. And the surgeon who introduced it to the craniofacial skeleton was Dr. Joseph McCarthy. And he was the chairman of NYU for many decades, who also happened to be one of my mentors when I was in the research lab. That's actually, when you asked before, how did I end up in craniofacial surgery? He was my first gateway to craniofacial surgery. I had no idea what it was until I saw one of his lectures. So he invented distraction for the mandible. He did it on dogs first, and then ultimately started applying it to different areas of the skeleton. So it's a great technique to lengthen bones in a way that allows bone to grow in between those two foot plates. I'm thinking of it as like a car jack. You're turning, and ultimately the bones at the areas of separation continue to move apart. But as you do it over time, bone grows in between. So it's a great option for us for a lot of cleft patients who will need jaw surgery, but the way their jaws have grown, there's such a big difference between where their top jaw is and where the bottom jaw is. where conventional jaw surgery would be really challenging to do just because of physical constraints. So having a distraction allows you to get much further and much more distance. That's not a perfect surgery. There are some downsides to it. You have to wear some type of device in order
Mm.
to do it, but it's a solution to a problem.
Yeah. I ask about that because so I mentioned also on the podcast that when Giselle was born, Giselle's my daughter, that they thought that she had PRS
Yeah.
and we eventually ruled that out. But I was just thinking about having to have a jaw distraction, how many children that are born with PRS have to have that. And I'm just so thankful that I didn't have to do that because I have a lot of empathy for the parents that do because it just looks incredibly painful. And it just looks like, I don't know, just the idea of having to tighten or go through that process is just, I don't know if I would have been able to do it. It
You're
would have
not the
been
first
so
person
hard.
to say that. I will say it's probably harder on the parents than it is on the patient because we will do some of these jaw distractions and it literally is a life-saving procedure. Yeah, especially these
Mm-hmm.
pure band kids who can't breathe just because their jaw is too small. So as Pierre Robin's sequence is basically a diagnosis of when you have a very small jaw or micronathia, you have glossoptosis, which is where your tongue is too big for your mouth, and airway obstruction. So I'll tell you a story. Before distraction was used consistently, there weren't a lot of great techniques to treat these kids. One, something called a tongue lip adhesion, where you sew the tongue to the upper lips to try to physically pull the tongue
Mm.
forward so they can breathe, or a tracheostomy, neither of which are really great solutions. But as more and more experience with distraction was gained, and over the last several decades, the more acceptance of it, recognized that it saves a lot of kids. So the other part of what I do is a lot of global health. I, I travel a lot internationally to do various surgeries, but also to teach and also help our partners. And one country I spend a lot of time in is Vietnam. And the Vietnam National Children's Hospital is the major hospital in the entire country. To give you an idea of scope, we have a lot of children's hospitals here in the US, and my hospital has a bed capacity of maybe 450. It's a pretty sizable hospital. They have 2,200 beds. They have a patient catchment of 40 million people. They do about 2,500 new cleft lip and palate patients every year. And the Pierre Robin kids, up until about 6 years ago, either got a tracheostomy or died. So we taught them how to do distraction. And over time, especially during COVID, when we didn't have an ability to travel, work together, they did it themselves. And over 100 kids are alive because of that. It is a life saving technique.
Yeah, that's incredible to hear. And it's a lot of this I've learned just in my own journey and that I probably have experienced more pain than my daughter has. She went through surgery, but mine was a very long, long drawn out emotional thing that I had to go through. And just for context, my daughter is cleft palate affected only. And so I didn't know till she was born. And so it was a surprise and a shock to all of us when this happened. But I felt like I was behind a little bit. I didn't know anything about anything. Yeah, so it was really challenging to learn everything on the fly. It's my first child. I was also a new mom, first time mom. And then also I had a child that had a cleft palate. So I'm learning a lot of things. It's like drinking from a water hose. And so, yeah, that was a challenge. And then to learn about that, oh, I may have to do these jaw distractions. And yeah, it just brought on a whole different level of anxiety and that sort of thing. But as you've shared, these are life-changing, life-saving methods that we've been able to use to really help children that are born with PRO band sequence. And I do have a friend, she was on the podcast and her daughter has PRS and they've really struggled a lot. And she's actually, interesting enough, she's in Australia and they don't do jaw distraction where she lives.
Mm-hmm.
And
Mm-hmm.
so she's had a tough time. And one of the things that has come up for her is about preparing her child to be able to have palate repair, right? And so I guess they're feeling like that her baby wasn't healthy enough to have the repairs. And thinking about that, like, where do you all look for in terms of like weight or like health for children to be able to go ahead and have their surgery?
I think you hit on a very important point. We want to make sure that the kids are healthy enough to safely undergo surgery. So historically, this was developed in the 60s, but there's something that we still teach to residents today called the rule of tens. And that means the child should be 10 pounds, at least 10 weeks of age, a hemoglobin of 10. These are soft guidelines, but they all basically tell you that the child can withstand a surgery that's going to have some physiologic impact at a young age. So most kids by 3 months who are otherwise healthy are going to hit that. So we do look at that. We look at the pattern of weight gain, and I've definitely had a few patients who, for a number of reasons, were just not really thriving. And we felt that these are surgeries, whether it be lip and or palate, that can be very helpful and are indicated. The risk and benefit ratio just has to be in their favor. If they're still so small, and the risk of anesthesia, the risk of blood loss, and those kinds of things outweighs the risk of the benefit of the surgery, we have to wait. We have to wait until they get bigger.
Yeah. I've only heard one case of this where there's a surgeon that does lip repair at 3 to 5 weeks or something like that. And so I guess how or why are they able to do it?
So I don't want to be a fire starter here, but I will say it's somewhat controversial. There are a couple of surgeons who are very adamant that there's a lot of benefit there. I think the major one that's proposed is that it allows the family and the parent to feel more complete and less anxious that they have a child who has a repaired lip early. The counter argument are those things. We do operations on very small babies, neonates, all the time at major children's hospitals. But for me, it's always the risk and benefit. Is the risk worth the benefit of waiting a few months until the child's bigger and having a safer journey through all those things? And I think that's just my personal belief. And I would say most centers in the US have a paradigm of between 3 and 6 months. And that's usually the rationale for it.
Yeah. And that's for lip, right? 3 to 6 months.
That's for lip. So the goal, yes, I'm sure you've touched upon this in your podcast, but just very briefly, the timeline of the cleft journey. Now, to your point, your daughter has an isolated cleft palate, so that doesn't mean she needs all of these things. But for a child who is born with cleft lip and or palate, there are a few things that are pretty predictable. Lip surgery, if you have a cleft lip, is the first thing. Actually, really the first thing is making sure that they're feeding well, and if you have access to it, some preoperative molding, whether that be nasal alveolar molding, NAM, or lip taping. That's usually the very first thing. And making sure that you're being followed by an accredited cleft lip and palate team. I think that's another thing I'm sure you've touched upon in your podcast. It's best served as a multidisciplinary team. I'm a surgeon. I know how to do surgeries, but it takes a village. It really does. And it takes a lot of coordination. Our team has speech and language, pathology. We have occupational therapists. We have geneticists. We have pediatricians. We have pediatric dentists and orthodontists. Surgeons are like the last wheel of the cog. So it really requires a team of experts who know what they're doing to care for this child and optimize them. So long story short, lip surgery, 3 to 6 months, at least in our practice. Palate surgery is different because you're weighing what are the reasons to do palate surgery. Clearly, there's a hole between the nose and the mouth. But also, what most people don't realize is palate surgery, the primary goal is to keep up normal speech. Because the muscles that are required to elevate the back of your palate are just not in the right position. And so the goal is to try and put them back into the right position while at the same time closing the hole. So we wait until usually 10 to 12 months to do. And that timing is because that's when the first words start coming out, and you want to repair the mechanism, the anatomy, before the child starts getting down a road of articulation errors and learning the wrong way to speak. So occasionally I will see, not so much in the US, but abroad, grown adults who still have unrepaired cleft palates. And their speech often is unintelligible. But the disappointing news is when I talk to them, I say, I can close the hole, but I don't think your speech is going to be much better because they've already learned these patterns of speech. So that's why it's important to do things at an earlier age.
Oh, wow. I didn't realize that. I have also heard of people having the lip repaired with palate. I've heard the standard being 10 months, 10 to 12 months, and my daughter had her repair at 10 months on the dot. So we've been seeing speeches, as you've shared, as a part of her journey. But I've heard of people being able to have their both repairs done at the same time. Now, is this because the repairs are easier? They have different types of clefts. Like, what have you seen in that where people have been able to do it at the same time?
Certainly it's feasible. Anything is possible. I would say, in my mind, it's not recommended because the goals are different. And also, there are some logistic aspects to it. To do a palate surgery, no, it's all inside the mouth, and you have a retractor that's basically putting pressure on the lips in order to get access to the mouth. In my mind, it doesn't make a whole lot of sense to do a very sensitive and specific surgery on the lips while you're manipulating the lips with this retractor. You're going to get swelling and all sorts of things. It doesn't make a whole lot of sense to me to do so. The only advantage is one, anesthesia, but I don't think that advantage really bears out long term. There is one, again, there's many controversial subjects in cleft lip and palate, but there's been discussion, particularly for going abroad with various NGOs, of doing the palate before the lip. Why do you think that is?
Yes, I do know. There's so many controversial things, and
Yeah.
I've been trying to clarify all of these things on this podcast as well. But sometimes I get the feeling like I don't know everything, so I'm open to hearing whatever. But I'm so glad that I have you, like, an expert here to be like this myth buster. But no, that's actually the first time I've ever heard that people that would be
Would
so
even
like
suggest that?
nerve-wracking. Yeah.
It's probably a reason you don't think about. So if you consider in a lot of different countries where the most visible thing is your face, but you don't really look inside the mouth. So what we found in some of the various groups that I work with is parents don't come back after you fix the lip because that's the only thing they see. So you lose a lot of patients to follow up. So the rationale is if you fix the palate first, but you haven't done the lip, they'll still come back. So
Ah.
it's an interesting way of thinking of things, but like I said, it's controversial. Most of our recommendations for cleft teams today are based on yes experience, but also some evidence and rationale from an anatomy and development standpoint.
Yeah. Yeah, that's fascinating. How many surgeries do you do per day? I know my daughter, she was the youngest patient. They saw her first thing in the morning, and that's what I've pretty much learned is the typical protocol. How
Right.
many are you doing per day?
It depends on the day, it depends on the surgery. Pediatric plastic surgery could be extremely straightforward and very quick, like taking off lesions like nevus or nevi in your face. That doesn't take very long. To doing the longest surgery I do is a 10-hour facial reanimation operation, where I would have to rewire some nerves and put some muscles together and use a microscope. Anything in between. As you can imagine, I can do 10 to 12 of those small cases in a very short amount of time, or one really big case. Anything in between.
Yeah. And I wanted to move in to talk like more specifically about the cleft lip journey. And I've asked this question to different moms and also professionals that we've had on the podcast as well. The use of the NAM device is a really difficult thing for parents to navigate and having to go every week and do those adjustments. Do you find it to be, as you've shared, like worth the outcome is worth the trouble?
In general, I would say yes, I think it's a positive. But I'm going to qualify it. And this is coming from, again, everything is just my personal opinion. NAM is very much dependent on who's applying the NAM because it's very user dependent. So having My bias is having a skilled and experienced craniofacial orthodontist is going to put you in a position for the best quality of NAM. We're very lucky. We have a highly skilled craniofacial orthodontist, Dr. Kristen Lowe, at Children's Colorado, who trained under the person who invented NAM, Barry Grayson at NYU. And she's wonderful, gets great results, and part of that is because of her skill set and her expertise, experience. So it depends on who's doing it. It also depends on just how severe the cleft is. Not every child needs NAM, put it that way. There are some who have what we call form fruits, or kind of minor clefts of the lip, and their nose looks pretty symmetric. Then there's not much of a role for NAM. It's not going to make significant difference from a surgical outcome. But you contrast that with maybe a child with a complete cleft lip and palate, where there's a pretty significant asymmetry of the nose. If the side of the nose, the ala is really flat, the gum lines are very far apart, the alveoli, and the lip is very wide. So I can tell you from a surgical perspective, that's definitely more challenging. So having NAM, being able to put all those components closer together, certainly makes my job easier.
Yeah, that's what I've heard. That was one thing that I heard that I also was just mind blown. That someone said, "Oh, it's just really, you don't need to do the NAM because all it does is just help the surgeon."
It's not so much helping an individual, it's more what's the desired outcome. I think every parent wants the best thing for their kids, right? We also have many patients who it's just not feasible, as NAM is more work intensive. It does require more regular visits. And it's just not feasible for every family, whether they're a working family or just they live far away. In our hospital, we see patients from 7 different states, anything from Montana all the way down to New Mexico and everything in between. So it's not feasible to ask them to come back every couple of weeks for fitting. That's why there's other options like Dynacleft or lip taping. There's other options. And I always tell parents that you should not beat yourself up whether you can or cannot do something. It's outside of your control. And these are all adjuncts. They're helpful if you can swing it, but you should not feel guilty if that doesn't work for your family.
Yeah. Yeah, for sure. If you can't do it, then that's understandable. I've shared here on the podcast and everyone that I've spoken to, I feel blessed that I have a pretty flexible schedule that I was able to go to all these appointments and do. But I can't imagine, had it been like 3 years ago, what I would have done, because I was required to be in an office and it was a lot different. And yeah, I can understand how that can be challenging. A question that I had that you made me think of is, so you were talking about the types of clefts. So why do you operate on a microcleft? I seen it written as microcleft. I don't know if that's the right term for it, but it seems like something in my eyes, right? That's very minimal, but people still have a procedure done. And sometimes it feels like it's creating a scar over a scar, right? Let's say. So what is the purpose of that?
Microform, or also known as a form fruit cleft, basically that's the most mild version of an incomplete cleft. And not all forms are the same. So that can mean just a notch at the lip, all the way to, if you look and you have them smile, or you can see the baby smile, there's a separation of the muscles underneath where the microform is. If you think about the anatomy from a 3 dimensions, it's not just the skin. It's also, there's skin, then there's the muscle underneath that, which is continuous. It's a ring around your lips, actually. And then underneath that is the mucosa, which is stuff inside of your lip. And that's what we actually repair anatomically, all 3 different layers. So not to make a pun, but it's skin deep, right? So if you see that, then there's potentially some things anatomically underneath that are not in the right position, and that's part of the rationale. It's up to the eye of the beholder too. There's a very famous actor. Let me ask you if you know who it is, who has a microform cleft lip that never got it fixed. Any idea who that might be?
Joaquin?
Joaquin Phoenix. If you watch his movies, it's noticeable, but clearly he did just fine in his life and career.
With that not getting it fixed, do you run the risk of like speech issues with speech or any type of thing like that? Or
not really. Speech is more of a palate issue, and so we're really talking apples and oranges there. If we're talking just the lip, that might have some implication on feeding or just getting at the lips to form a seal. But a lot of it, really the functional aspects, more often is the palate.
Yeah, that's so interesting too, because it's like I've had so many conversations with parents that, of course, when you have the lip, you want it to be repaired because of the outer physical appearance of your child, and so I often go back and forth whether it's like would I what's the harder journey, which is like wild to think about, but it's like would I have rather just have the lip or just the palate? I honestly I wish neither, but yeah, I think about that, and because I think about it being such a surprise, had it been the lip, then I would have known. But just in thinking about the palate repair, many mothers panic about getting their baby off of the bottle before the surgery. One of the things that happened to me, and I've also shared this on the podcast previously, but so we were told it wasn't like a you have to get her off the bottle type of thing. It was just like, we strongly encourage you to get her off and we want you to do that. And so I worked with my daughter and we were able to get her off of it a little bit, like enough to feed. But then after surgery, when I saw my surgeon, she's, oh, you're okay to still use the bottle with the valve. And so I was thinking to myself, like, so much panic and anxiety to get her off the bottle just to be told
Yeah,
she's
right,
okay. So what is your
right, right.
approach to that?
Like you've already pointed out, there are no hard and fast rules. There are general recommendations, and I'm a pretty practical person. I have to have rationale for everything that I explain or that I would recommend. And if you think about it, if you're putting a palate together, it's a pretty tenuous repair early on. It's just held together by stitches. So anything that could disrupt that healing, whether it be a finger in the mouth or the nipple of a long nipple of a bottle or something that's hard, then that makes the surgeon nervous for the wound healing. Also, creating negative suction. It's different after a palate repair. That child doesn't know what to do yet. This is a totally new anatomy. They have to get used to it as well. So those are some of the rationale for recommendations. And as I'm sure you discovered, your baby is not going to be super happy the first couple of days after a palate. I don't think you or I would be very happy, So you just have to take it with a grain of salt. So we recommend whatever is necessary to get nutrition. So that can be, we try to recommend a sippy cup if they've been on that before, with a soft tip and a short tip, because it does provide some passive fluid. Sometimes even the first night in the hospital, they'll get a syringe with a little flexible rubber catheter. That's pretty common. Some of the passive methods of getting fluid, hitting the nipples, etc. There's all sorts of different techniques. The whole goal is just to make sure that you get adequate nutrition and hydration to your baby for the first several days or most.
How long is that healing process for palate repair?
All things being equal, things start to get watertight. This is all wounds, not just palate. Things start to get watertight by around 2 weeks. That's not to say go to town and party at 2 weeks, but that's when the initial cells have migrated over it, and you have a bit of the palate repair is also in layers, just like the lip. You may see there's a hole, now there's no hole, but underneath that, yeah, most surgeons will first repair a layer, what we call the nasal side, it's mucosa. Then they'll put the muscles together in the back. That's called a intravelar veloplasty. Basically, that's what allows you to have normal speech. And then, of course, the oral side, which is like, so all of those things have to heal, and all palates are not built the same. They have different widths, they have different lengths, and levels of completion. So some are easier, some are harder. And as you can imagine, the harder ones, when they're wider, have more tension on it. In palate surgery, it's definitely undergone some evolution. Depending on your surgeon and their kind of bag of tricks, they may recommend using some tissue from the cheek, something called a buccal flap, to help augment that repair, especially if there's a lot of tension or buccal fat. Yeah, these are diving deep into the weeds, but there are a few different tools in the armamentarium, more so now than there used to be. Let's put it this way: when I was training, we didn't have a lot of these tools, and they've been helpful. I think it's just trying to find the right thing for the right patient.
Yeah. And thinking about that as well, why do palate surgeries fail if they do, usually?
Yeah, there's a variety of things. So surgeon technique can be part of it. in general, how do things heal? You need good blood supply. So when I say surgeon technique, is it meticulous dissection, just being very careful handling tissues? Usually that's actually not the reason. More often it's other kind of anatomic techniques. Like I said, the wider ones, when a palate, if you see a bigger hole, it makes more sense that that's going to be harder to close. Right. Also, things like infection, things like nutrition, things like physically sticking something in there. As you can imagine, kids don't always listen to you, and even under the best circumstances, sometimes they find ways to put things in their mouth. So all of those things are go into go into the equation.
Yeah. Does your office also do bone graft? Or is that oral?
I do both that.
Bone graft.
Yep.
Okay. I've had, I guess, a lot of parents think about, they're so focused on lip and palate, right? And then you have this like long waiting period where you're not really, your kind of fears are able to subside a little bit. And then, you're rushing to prepare for bone graft. And then obviously your child is a little bit older now. So it's a different type of surgery. So how do you prepare parents for bone graft?
That's a good question. I guess before I answered that, I realized I didn't finish the original question of what's the timeline of cleft care. So after your lip and palate, actually before bone grafting, the next thing that might be on the docket is speech surgery or VPI. You probably heard of that. That's velopharyngeal deficiency or velopharyngeal incompetence. And they usually figure that out around 4 years old as they're being assessed by speech pathologists. So that's not everybody, but that might be the docket earlier than a bone graft. The idea of a bone graft is if you have a hole or a cleft of the alveolus or the gum line, then you can imagine that the growth is of some consideration. So the reasons to do a bone graft are to number one, to stabilize those two segments or three segments of your gums, your arch, so it's one piece. Number two, probably the most important one, is to have enough adequate bone there so that a tooth can erupt. Because teeth have roots. And so for an orthodontist, they'd be able to manipulate the teeth and get them straight. They need a rootstock. So they need bone because you can't really do that in a big gap. And lastly is if you have the best possible scenario is you have all your teeth, but you're missing one, the lateral incisor is the most common one. Then there's enough bone there that they can put an implant, a dental implant. So that's the rationale for bone graft. But to your earlier question, how do you prepare parents? Bone grafting is not new. We've been doing it for decades. How we do it and what we use is evolving. And again, another area of controversy. So the traditional method is to borrow bone from your hip. And that's different techniques to do it to harvest the bone. You're just taking these little cancellous chips, which is basically the soft stuff outside the hard other part of the hip. And you want to make a sealed box where the hole is. So you close the nasal side, you close the oral side, and basically create a pocket so you can put all this bone in there. And then you wait for the bone to take. It doesn't have a blood supply, so there's definitely going to be some level of absorption. We don't know how much. So there are different risk factors. That's why surgeons should say there's a risk of regrafting. Right? Despite how much we've put in, we can't control how much of it sticks around. But there are some alternatives. Different surgeons have different practices. For instance, in mine, we've been able to optimize it. I actually, my technique is to use a very small incision, and I use a little drill, which allows me to make a small incision. And because of that less invasive technique, kids are going home the same day, and they're bouncing back quickly. In fact, we wrote a paper called "It's Hip to Go Home."
Yeah, way to make bone grafting cool.
I got to give credit to my former partner, Dr. Matt Reeves in Houston. He came up with
that. But yeah, and then the healing for bone graft, how long does that usually take?
There's the primary healing, which is just healing from the site. And again, we have stitches in the gum line, and if you're taking things from the hip, you have stitches there, and that heals, again, 2 to 4 weeks. So that's to heal relatively properly. But then every surgeon's a little bit different in terms of what they recommend for activity restrictions. I always say, listen, as long as don't brush your teeth here, don't participate in contact sports for a minimum of 6 weeks. But if you're just going out and just walking and non-contact activities. I'm not going to restrict you.
Yeah. Has just going back to what you mentioned earlier, the VPI. So that one is really one that is that the surgery that you would have to extend the palate or um that's
It's one,
so
yeah, that's one technique. Uh,
yeah, I've heard about this because of course since Giselle is born with a cleft palate, they one of the questions is how many
yeah.
surgeries that would she have to have? And so they said maybe two. And I think that was the one that they were probably referring to, that if her speech, if she wasn't able to speak well or articulate properly, that would be the
Mhm.
surgery that she would have. And it's creating the seal, right? Like for the palate. I'm explaining this in really bad terms, but yeah.
No, you got it. That's essentially what it is. The whole idea of BPI is that there's too much space between the back of your palate and the back of your throat. I don't think your podcasters can see hand movements here, but the idea is that when we're making speech, you have to have some touching of the back of the palate to the back of the throat. And no matter how good of a surgery you do, it has to heal. And when things heal, sometimes it contracts. So even if you have a palate surgery that went really well, things that we can't control is, does it stay that same length, or during the healing process, does it start to shrink? So previously, when I trained 10 plus years ago, the teaching was build up the back of the throat. So that's either called a pharyngeal flap or something called a sphinctopharyngoplasty. And the idea is build up the back of the throat with more tissue to make that connection. It's funny because the paradigm is now shifted towards, instead of working on the back of the throat, making the palate longer. Single, making them connect. And the idea here is more physiologic, more consistent with normal anatomy and nature, and there's a few techniques to do that. So it's funny, in my practice, I shifted towards that too. And I've been very happy with it.
Yeah. So far I've had two speech evaluations for Giselle, and they basically told me that she's not going to need speech or anything. And I had always been under the impression that this was just a part of her journey. And I had two evaluations because I was being pushy about it. Because I'm like, is she, I was expecting her to have some speech issues. And so they were like, no, nothing to see here. And then I'm like, no, evaluate her again. And so I guess in that case, her first repair was done enough to where she's not, I guess right now, right? They don't see any indication that she would have to have any type of speech therapy.
I think if you have a good relationship with your team, they're gonna help guide you through this, because it's easy to go down the rabbit hole. When it's your child, you're one of one, so you're locked in and focused on every little detail. But it's good to have a team because there's a little more context and perspective if that team is taking care of hundreds of kids.
Yeah. And the one thing that is, you're so right about that, about having the team, because she told me as well when the speech pathologist saw me during our annual Cleft team visit, she said, you're going to see us every year. So if you have an issue next year, then we're going to see her. So don't worry about it. And I said, oh, that's a really good point. Why you are going to see her every year. So she'll be evaluated then as well. So nothing, I can, it was the first time, and she's a year old now. She's actually going to be 2 in August. And for the first time since she's been born, I feel like I can breathe, like that she's going to be okay. After rhinoplasty, that is pretty much like at the end of the journey for many adults, unless they want to have their revision.
Yeah, I would say that's the expected journey. And then why we don't have adult teams, because they're the same needs. And so I will still see some patients who are fully grown adults who are now thinking about some of those aspects, maybe a little lip revision, maybe touch up of the nose. So I think of that as kind of touch up surgery.
Yeah. Thank you so much for going through the journey with me. I think some moms are really interested in knowing exactly, what happens at each phase. And some of us are really interested also in knowing the more technical aspects as well. So thank you for providing like the context for that. But just in closing, what do you think is the best advice that you would give to someone that is along this journey and that is seeking support or questions from a cleft surgeon?
The first thing I say when I meet an expectant mom, prenatally or a new diagnosis is take a quick deep breath and just remember that your child's going to be just fine. They're going to be okay. There's going to be a journey, but you're not alone. There's support every step of the way. Your family becomes our family, and vice versa. And so that's one of the most incredible things about working with kids with cleft and families with cleft is you get to know them over time. And so I say this is very scary, but after that, then there's going to be a step. Once you get past the first few steps, then it gets easier and easier because now there's an expected pathway. And we know we've traversed this before multiple times. Let's let your team help you.
Yeah, absolutely. Thank you so much, Dr. Nguyen, for having me and for joining the podcast here today. I'm so grateful to have your expertise. Thank you all for listening to the Our Forever Smiles, Cleft Mom Diaries, and Support podcast. Be sure to subscribe and submit a review of the podcast wherever you listen. I hope that you've enjoyed this audio experience. Maybe you cried a little, laughed a little, but more importantly, I hope that you feel a little piece of reassurance and even joy in your journey. Talk to you next week.